Oh no, wrong one. Wait a minute. Great. Okay, so I hope everyone can see. So we're doing osteopathy and endometriosis. And for those of you that don't know, I'm always keen in osteopathic medicine. And I can't be bothered to see anyone with low back pain. Boring, dull, can't be doing with it. Send them all to someone else. But I don't do visceral, despite the fact that I've written a book called Visceral Osteopathy. So it's osteopathic medicine, which is what we're going to be going through today. I've made some presumptions. We'll see. Anyway, here is some good reads for those of you that don't know. That's a free handbook, enormous, lots of pages, lots of research. The Palgrave Handbook of Critical Menstruation Studies, free. And if you want, there's a good section in there, one of those that I've picked out. If you don't know any Facebook support groups or study groups, Nancy's Nook Endometriosis on Facebook has got thousands of files and bits of research and discussion. So, you know, if you're into the topic of endometriosis, then that's a good place to start. It's not a patient support group, it's a study group. Yeah. So osteopathy and endometriosis. So my first question is, I'm known as the orificial osteopath, but I don't do just PRs and PVs, all right? I do other orifices, but I also do non-orificial things. But people think that if I'm going to be doing something gynecological like endometriosis, then it's got to be a rubber glove job, which it could not be further from the truth, all right? And also, my answer is that visceral technique does not equate to osteopathic medicine. So if you finishing your school and you think that endometriosis is to start rummaging, then you've been taught entirely incorrectly, all right? Because it's all about understanding physiology, because osteopathy is a physiological philosophy. It's not a biomechanical science. Okay, so just clarify that. So, and then my second question is, or my second statement is there any evidence for osteopathic research into endometriosis care? And the answer would be, any guesses? No. Okay, fine. Because you've been, well, euphemistically, I'll say that people are often taught these days that if there's no basis for it, i.e. no evidence, then there can be no education in this field of care. So you shouldn't be taught about it, right? So I shouldn't be here saying anything because there's no evidence, which is bollocks, all right? But I'll explain in a nicer way. Obviously, all the usual stuff about the absence of evidence is not evidence of absence. All right. And obviously, there can be lots of debates about how you formulate your evidence informed practice. But I feel exceptionally strong that where you're told there's no evidence for osteopathy, that leads to the stance, as I said, that only that which is evidence should be included in your educational program. And I feel that's wholly inappropriate. No one would say to acupuncturists, oh, I'm sorry, there's no evidence about acupuncture, so we won't have you doing that needle thing because, well, that's not part of it. We'll just give you, you know, help you do exercises or something, or moxibustion, maybe there's some evidence for that. And it's not acceptable because when you drill down to it, the actual osteopathy part, not the exercises and not the being nice to patients and having good practitionership stuff, the actual sort of hands-on physiological interaction part has been very under-researched. So it is impossible to say that there's no evidence when you're implying that through that statement, that therefore, just because people haven't researched it, there is a lack of evidence, but that's not the same as evidence which shows that it is not of any value, not of any clinical use, has, you know, adverse risk and so on. But people conflate the fact that, oh, well, there's no evidence out there, so therefore it doesn't work. There's nothing to it. It's all hogwash, and it should be left as pseudoscience. And you know, that's why no schools teach it as part of the mainstream curriculum these days, because you're on to better things, aren't you? You know, evidence from outside. But I think that if you have a philosophy, which is part of your origins and hopefully your ongoing dynamic, that you need to still understand what those concepts are, you need to still have some skill sets, you need to still have some interest in it, so that actually, regardless of what current science says, you get to formulate some questions which can then be researched. Because unless people are still trying to answer, well, how does it work? How does this work? How does that work? You can only generate those questions if you become embedded in it in your training and you've got some hands-on concepts and so on. So that's really what I'm wanting to go through, because that's what research capacity building is all about, is actually having you faintly interested in the topic and willing to pursue it further. But of course, if nobody tells you it, then you've going to have no interest, and it'll all just, die a death and, etc. So we really must be able to explore practice work which might not have much efficacy research, but that does not mean to say that there is no founding framework on which it can be developed. So there's lots of ways that you can build up an evidence framework which is respectful of that scientific awareness, so that we can build up these sort of novel hypotheses that can be tested without going mad and doing something totally spurious and unfounded. Endometriosis itself is extremely complex. It's difficult for anyone to research it. So when you actually look into what helps endometriosis, you'll find there's bugger all that's consistently thought to be helpful. It's really a challenge. It takes many, many years to diagnose. Half the people that try to do excision surgery aren't trained for it, because half the time your adhesions might be in the bowel, but if you're not a bowel surgeon, then you won't touch that bit of the bowel, so the person gets left with their lesions in place. It's very complex. Okay, so it's endometriosis is a real challenge, and there is definitely that political thing, because it's a woman's thing, and you can't see stuff. There's no big blotch that will, no, your leg's not missing, and it's really there's a huge gender issue about misdiagnosis and sort of all of that, which we haven't got any time to go into today at all. So I am presuming that these days you're taught to have a healthcare role. That's what your program is about. Your degree is about being a healthcare practitioner, but that's not the same as being able to practice osteopathy. In my view, the two things are very definitely different. Everyone and anyone can have a generic healthcare role understanding. That healthcare role might include, all sorts of adjuncts like exercise, patient-centered care, empathetic therapeutic alliance understanding. None of those things are specific to osteopathy, but it may be that that formulates a huge part of what you do. And then if the hands-on part that you're taught, hopefully you're still taught hands-on in the post-COVID era, but you would hopefully be taught that you're doing something hands-on to have a physiological effect or a fluid effect, and not just some sort of biomechanical leverage effect. So you're not diagnosing musculoskeletal medicine, you're actually diagnosing physiological dysfunction, disabilitation, and all of those sorts of things. So I want to try to say that I think that it's a challenge for you in order to remain physiologically embodied with your understanding of osteopathy, because there's lots of people that would like, for a whole variety of reasons, to dumb it down for you, simplify it, and sort of welly you into a generic healthcare and musculoskeletal rehabilitation role. That's why you came here. Great, lovely. Sorry to be so rude, but I think that osteopaths can do a lot more. So osteopathic care should include osteopathy. I'm not sure that it actually does so much, but when you then drill down into how you can practice osteopathically, there is quite a lot of substantive increasing evidence these days about the plausibility of the scientific rationale underneath it. Yeah. So we all know about Sackett and evidence-based models, and we have to include the biopsychosocial and all of that sort of stuff. But osteopathy itself was always biopsychosocially oriented. Just because psychotherapists didn't originally understand how influential the body was onto the mind, they had to come up with biopsychosocial medicine to orient their own practice into a better framework. It's worked very well, but that doesn't mean to say that we need to have it imposed on us because we don't understand it, because we always did understand biopsychosocial, the person as an individual, organising them in their environment. I don't see that we didn't do that. And I find it quite confusing that people try to claim that that's the case. Obviously, Sackett himself, part of the dynamic is that clinical experience, clinical expertise, that information that you can only get from the individual was to be included in your framework alongside the best available evidence and all of that sort of stuff. It seems to be that obviously that observational sort of study, that in-person experience is continuing to be eroded. And I would argue that actually there is a lot of movement in the research world, and especially from the social sciences, about the fact that observational evidence can be strengthened quite considerably. And if done well, N=1 studies are quite informative and able to be synthesized. So I don't feel that the randomized controlled blind trial thing is going to be the end of the story. And I think that there are emergent other ways of doing research. If, of course, you're interested in the topic and you've got a bit of grounding in it, so you can do some sort of little pilot case study and then get some sort of like consultant interested and then use his ethics process and start part of his funding and then hopefully get a bit of work done. So it's tricky. So there is a challenge about practicing when there isn't quite so much evidence as people say that you would like to have or should have. But again, it's all about the underlying plausibility. What are you founding your hypothesis on? So as far as endometriosis is concerned, what on earth do we think causes it? Why does it arise? And what could there be in manual therapy or osteopathic approaches that may be relevant? And is there any evidence for that concept as a contributing factor? But because most people aren't asking the questions in the same way, like, why would abdominal massage help reduce inflammation in the abdomen? What good would that do a person with endometriosis? Very few people are asking those questions. So of course there's no evidence, because they're not asking the questions that we want to have answered. Yeah. So you have to be quite robust in your, you know, thanks very much for saying that sort of, you know, reply. Thanks, but no thanks sort of thing. And by the way, it's not all placebo. Because that's the other hoary old chestnut, isn't it? You know, that oh, well, you know, whatever, you're just smiling to the nice people and that's making them feel better. And, you know, there's nothing really in it. You're just trained to be empathetic and that's what you do, isn't it? But it's really interesting when you start to put trials together that there are ways of summating lots of different evidences and comparing them such that you are left with a bit which is beyond placebo. And I think that it's in that arena that we can build up some dynamic understanding. And anyway, quite frankly, if you get to enhance the placebo effect, that's a good thing, isn't it? Sorry, why is that so bad? I don't get that bit, but anyway. But the actual role of the patient-practitioner relationship, it's dismissed as placebo. But when you actually get into understanding interoception, the autonomic nervous system, and the way that people co-regulate each other, there's some fascinating research whereby the manner in which you're at, the way that you approach, the way that you engage is actually then going to start co-regulating and engaging, changing their physiology based on how you control yours. And I don't know where you're at with cranial involuntary mechanism and biodynamic work, but most of that stillness stuff is a co-regulatory effect. Back of the membranes, it's got nothing to do with where the sphenoid is. It's a method of being, which is a way of absolutely interacting physiologically with the person that you are with, and creates a lot of beneficial autonomic resolution but it doesn't necessarily make any difference whether you do or, you know, this, but, you know, this, it doesn't really, a lot of it doesn't matter, but that doesn't mean to say it's not effective. Yeah, but there may be lots of things going on. So there's also people's people have agendas, you know, benign agendas and all the rest of it, and this is such a great one, as in you know, trying to understand how we would have inflammatory effects. What's the basis of it? Paper number 1, somebody saying back, well, that's really no good, you know, you made all sorts of errors of bias and sort of conflation of results and all of that sort of stuff, and it's really doing the profession down in order to produce such a poor piece of work. And then there's the counter effort saying, actually, I think you've misread all sorts of things, and that you've perhaps yourself made some form of misrepresentation in your response. So research is about having a conversation, and it's quite likely that many people are not going to agree, never quite going to agree. But I think this debate is really important, because when you get to the bottom, the defense of we need to explore, which is basically what the last paper is extremely valid. So we have to try to, with the imperfect science that's out there, actually draw strands together so that we can then see if we can bring enough together to formulate something which can be explored by someone with. So it's too easy to chop people off at the knees. I mean, it is, it's just incredibly easy to do that, but what's the value of it? Yeah, in my view. So I have put some bits and pieces in there where everybody recognizes that, you know, you have to have rational scientific and methodological principles, but they're not in themselves sufficient without taking a broader sort of clinical individualized perspective. So as a clinician researcher, which is most of what you're going to be, you have that responsibility to try to bridge a gap. And so there will always be this sort of dual role that you have to play, which is almost inventing and researching as you go with every patient, which is a fabulous thing. And as I say, case-based research approaches are getting much more accepted these days. There are ways of systemizing them and so on. So it's really valuable. And when you build a theory from cases, there's all sorts of opportunities and challenges to that. But of course, A.T. Still was the greatest theorist that we can make reference to, because he saw a lot of cases, made a theory, and he's still waiting for some bastard to come along and fully research it. Excuse my French. But so there are some theories, yeah, and I completely accept that, you know, if you help people to do exercises, if you help people to do mindfulness, if you help people to have a better diet, if you help people to, you know, see a psychotherapist because of their relational issues, if you do all of those things, it's fabulous. And of course, a modern healthcare role includes all of those things, but absolutely none of those are to do with osteopathy. None of them whatsoever. There are things that with the title of osteopath you get to do, but that's not the same, as I said. And it's also about you don't have to cure things. So people always say to me, Caroline, well, yes, but you're not going to cure endometriosis, are you? And I said, no. I said, well, there we are then. And off they run. And then I get people come along and say, well, thanks, Caroline, that was a lovely lecture. And I did that, and I rummaged around in someone's tummy for 2 sessions, and they were no better. And I thought, yes, but it obviously doesn't work then, does it? Because like in 2 sessions, you know, it should have been cured by now. Or I did that last week, you know, I rubbed that bit. So I've done that bit, and it's not better. So, you know, visceral's useless. I'm saying, well, you shouldn't have been doing visceral anyway. You should have been doing osteopathic medicine. And then I say, well, how would you think about endometriosis in terms of, or any complex and chronic systemic or visceral disorder? So park that. Musculoskeletal world. If you had someone who's 75, crumbling knees everywhere, completely inflamed hip, and I said to you, right, here's a really good technique for the fibula, go away, do it twice, and you'll cure them. And of course, you aren't going to change all of that degenerative change. You're not going to remove all of those osteophytes. You're not going to be able to repopulate that cartilage. You're not going to be able to get rid of their adapted gait pattern, you know, after 20 years of waiting for a hip operation that's never going to come. So in a musculoskeletal understanding, you would not expect that you would cure the osteoarthritis of a 75-year-old person. But that doesn't mean to say that you think that there's nothing that can be done. You'd think of loads of things that would be done, wouldn't you? And that's supporting the patient, but that's valid, isn't it? Yeah, that's valid. But it seems that something in the head of osteopathic students or practitioners that sort of goes a bit weird when they come to think of the viscera, and they think if it's a visceral disease and it's not cured in 2, then therefore there's no contribution to be made. So this is what I want to try to illustrate to you today. What is it then that we can do anyway? So I've got some experiences and so on that I want to try to share, but I also want to try to draw in the sort of evidence that is emerging that helps us know a little bit about that. Anyway, there are a couple of little case studies. I've just put in one about osteopathy and endometriosis and chronic pelvic pain. So you've got one little reference there. So I haven't done it exhaustively, but there's just a little bit of paperwork. And I'm trying to come at it from a care plan approach, in the sense of this is not a recipe of what you do. This is a recipe of what you explore. So if you can explore something and understand what it is that you're trying to explore in someone who happens to have endometriosis and all sorts of other things that go with it, then you'll be able to have a look and then find in them those bits which are actually relevant, and then you'll be able to have a go at treating them and see if you can then help to resolve those. So with all of the things that we want to try to do, it's understanding not just what endometriosis is or how it arrived, but if someone has endometriosis, what does it do to them? How do they experience it? What changes? So I'm just pushing all the wrong buttons. Wait a minute. So, all right, some pictures. Endometriosis in all of them. And although the light's not great, you can see that the picture on the right is, has an abdomen full of leached blood everywhere. There's all sorts of cysts of endometrial lesions, there's bits of adhesions in there. And then the woman on the left almost seems to have nothing. Yeah, there's just a tiny little blob or bleb. There's no free blood in the pelvic cavity there. Now, who's got the most pain? Hands up for the left. Good job. Hands up for the right. Good job. No, you've got no idea, really. Yeah. What you see bears no relation. So this woman could be having the most staggering pain, and there's nothing to see. So of course it's easy to dismiss. Yeah. The woman on the left could be utterly pain-free. Wouldn't know she's got it. Amazing, isn't it? So there's something about endometriosis which isn't actually anything to do with the endometrial lesions per se. So that's the first point, all right? There's something else going on. And the easiest way to think about it is it's a bit like cancer spread. We know now that it's as much about, even if you, there's the issue of whether it does or doesn't seed. And then if it's seeded, can it actually travel? And then once it's traveled, it's all about the status of the tissues, which it's then might be implanting in. So it's not going to implant unless something is changed within the tissues at that distal site. And endometriosis is a bit like that. And the preparatory story about endometriosis is one of having a lot of inflammation, either within the abdominal pelvic cavity or within the autonomic nervous system. So it's a dysautonomia and a pro-inflammatory story, which then sets the scene for, if you bleb a bit of endometrial tissue around, it can then implant much more easily. And all of that information makes nerves grow into the area that much more enthusiastically. And of course, once you've got nerve ingrowth, what do you think you get? Yeah, sensitization and pain, basically. So if there's no nerves that have grown into it, it will not be painful. Yeah. So not all of these things have nerve ingrowth or have nerve growth factor on histological dynamics. So it's tricky. So we've got some models of osteopathic care, structural model, respiratory model, metabolic, yawn, blah, blah. And it's not necessarily very helpful to split them up in that way. because as we know, your structural model may give adverse neurological input contributing to a neurological model. And the neurological model with your autonomics gives you a behavioral component. And the way that you breathe gives you a metabolic effect. So it's not necessarily very helpful in practice, because you can't, sorry to say, go along and say, I'm going to do my respiratory treatment now. I'm going to do my metabolic treatment, and then I'll do structural, what was it? Something, oh yes, something on the list. We'll do a bit of nerve stretching, that'll do. So you can't apply it like that, okay? So in and of themselves, they're not really as helpful as you might think. So just go back to structure governs function and just understand it with respect to the soft tissues that you feel, and bones are soft tissue. So soft tissues, it's all of them. Go to how the tissues feel, because the state of the tissue, the reaction, the histology will give you a physiological understanding about what that tissue is or isn't able to do. And so when the tissues don't feel right, they will by default be having an adverse physiological output, which will be giving adverse or dysfunctional feedback. So adverse sensory information contributing to a whole variety of stuff. So I'd rather that you thought about osteopathy as a somatophysiological bodywork type thing, where the only effect that you're trying to have is to change the physiological process in the tissues. Because if you can't work out how what you're going to do makes a difference physiologically, there's no point doing it. Yeah. And I'm not going to say here, have a big list of saying, you know, treat this, and this, because what you'll do, you'll go there and you say, right, Caroline said, oh, doesn't work. Okay. So as I say, you have to examine, and only those bits where you find something which is asymmetrical, aphysiological, awkward, providing adverse sensory feedback, then you can work on it. Yeah. So that's the approach that I like to try to do. And it's always, because of that, individualized. And you can always, once you've seen them once or twice, you can see what changes and what doesn't change. And in understanding what's not changing, you can then reflect and draw in from their wider dynamics. So for any condition, we're going to just think about the rationale behind it, the anatomy behind it, quality, and so on. So with endometriosis, we can build up an evidence framework based on, for example, we've got physiological adaptation and functionality that we can think of. There's treatment that we can give, there's exercises and posture, yes, there's habit retraining, there's self-care, and there's lots of ways in which we can measure things. So we're going to understand a bit of anatomical basis. We're going to understand a bit of the physiology behind it. We're going to talk about the treatments, but also, you know, a few bits and pieces with exercises, but I'm going to try and stay off the adjuncts. Yeah, it's just what we can do and what we're trying to influence. We won't today do outcome measures and efficacy, and we're not necessarily going to speak about working with other professions, other than to say that I hope that following this, you will be more reassured in your ability to communicate what you are trying to do, and therefore where you fit in into the healthcare system. So when we look at people with endometriosis, they don't just have endometriosis. So we treat the person, but within that, we have to still understand why they've got endometriosis and they haven't. That's the fascinating bit. So we're just looking at all of that sort of stuff, and all of the things that I'm talking about, because there's just no way that I can go through all of these bits and pieces, which is why I have developed a whole series of courses about this whole sort of osteopathic physiology, philosophy, models of practice, and so on. And you've been given a discount code for that if you want to, or not, I don't mind. But because what I can say today, you know, we've only got like an hour. It's just like 1% of the way that I help people that have endometriosis. Okay, so just going to get a tiny little insight. So we want to understand with endometriosis what's going on. It's not, it used to be thought that you would have retrograde menstruation, therefore you'd bleed back into your abdomen, and therefore the endometrial tissue would just settle through the abdominal cavity where it's not meant to be, and therefore seed and get stuck. So as I've said before, people now don't feel that that's the real story. And there are lots of, people don't really know, for example, why you can get endometriosis in your lungs. You know, what about extra, you know, you can get it in your nose, you know, well, how does that work? What's going on there? That there are all sorts of intriguing things genetically, embryologically, about different types of spreading. Some people say through the lymphatics. So there's no one theory really nails it, okay? But increasingly people understand that the problem with it becomes when this pro-inflammatory status in advance, but once you have it, it then sets up inflammation, nerves grow in, nociceptive foci arrive, and then more and more, you know, reflex irritability is set up, and you get lots of cross-sensitization everywhere. So I'm going to show you a tiny little bit of a video, and we'll just let it play. So this is a bit of a laparoscopic thing, if I can find out which tab it's on. Here we go. So I'll just need to, the sound's off. So this is a, wait a minute, do the lights go off or not? Anyway. So this is somebody looking over the top of someone's bladder. So suprapubically, when you press down in front of your bladder, you get this nice smooth surface. Then this is the uterus, obviously bobbing up and down with a probe in the vagina, and that should be flopped over the bladder. So we've got a nice slippery surface. The uterus should move. Either side, we've got, that's a round ligament, by the way, embedded from the uterus through to the deep inguinal ring. There we are, that's the round ligament, which is supposed to have smooth muscles in it and be contractile and cause pain. Here's the other one. So of course, if you've got sort of spasm of that, it will give you pelvic pain. And if you've got inguinal abdominal wall tension, that can be a problem, aggravates it. There's a fallopian tube. There's some veins with the fallopian tube. See how slithery and difficult it all is? You know, you can imagine just getting hold of that and just going sliding straight off. The ovary is the white thing, by the way, and the thing at the very bottom is the bowel. So what he's then showing is that often you have to sort of flip up bits of these organs. And so he's trying to pick up that ovary and sort of get into the back of the round ligament, because underneath, tucked underneath there, right down at the back of the broad ligament, you'll see some little blebs, tiny little blebs. Oh, there you go. That's a bit of endometriosis, so that might need to be lasered away, because that might be producing horrible pain or not. If we're looking right down into the pouch of Douglas in a minute, which is, you see how slidey it is? You know, when you've been taught in visceral, you say, oh yes, I can do this ligament, and I can do this one, and that one. It's all a load of rubbish, okay? Because you're forever just going, right? And you can't feel what you're on. So anyway, there's a bit tucked right down in there. That's a deep pouch of Douglas. That'll give you a lot of pain when you're having intercourse, because of course it's right up the top end of the, if like the external surface of the vagina. So all of this glistening stuff is peritoneum. Now, peritoneum is completely fascinating, highly innervated, and suffers and contributes to a lot of the problems that we can see. So to do the laparoscopy, obviously they've had to inflate the abdomen with a lot of gas, and all the other organs are out of the way, but there's no way you have this space. You know how viscera work? You know, you put your hand in a great big jar of rice and you run it in, and then you can't get your hand out because all the rice has fallen in. And anyway, you take your hand out and all the rice falls into the hole. That's just what your viscera do. So you try to move one bit, they all go, and it becomes difficult to grab hold of them. So your aim isn't actually to grab them individually. Your aim is to do something sort of generic. So we're just looking to the other side. And again, if your surgeon's not careful, unless he picks up every little flap and fold, he's not going to find all these little pockets. And if he leaves one behind, there's no point having had the surgery, because you'll still have the pain. So you have to be very skilled as an excision surgeon in order to dynamize or get this whole area sorted out. And in a minute, one of the things I'm going to show you is that he's been looking this way. He's going to very quickly turn and look north, there'll be this sea of viscera that he's going to look over. This is just prodding on the top of the uterus. Now that shouldn't be puffed up. That's because it's got adenomyosis in it, so it's swollen from within. Okay, so there's no ligament to release on that one because it's within the body of the uterus. Here's it going up to the cecum, the right ascending colon sort of area. You're going to pick up all those folds, and who knows where your appendix is. Your psoas is deep underneath there. Who does this for the psoas? Yeah, who finds all those lumps? Yeah, great. Colon, root of the mesentery. So I could wax lyrical about that for days. But so anyway, viscera, gallbladder, edge of liver, underneath the right dome of diaphragm, all falciform ligament, that's enormous. And carefully look, any minute now, underneath the dome of the diaphragm, heart. Yeah, fabulous. Anyway, I love that video. So you've got, there's all the viscera. So you imagine trying to rummage through that lot with certainty. So the answer is that that's not your aim. Your aim is to work out how it should all nicely slide, how all the peritoneal fluid should be, how you desensitize it all, and how you stop the bladder also irritating the gynae structures, or the colon irritating the peritoneum, or how the pelvic floor is contributing to the sensitization of your rectum, for example. So just 2 seconds. So that gives you a little bit more of a visual insight. That's the wrong talk. Okay, so as I said, it's about nerves, and I'm not going to go through all of these bits of pieces of paper, other than to, I'll point this one out. Go and have a look at this one. This is where they did some viscera on a rat, and they gave it surgery, and they did, one group had osteopathy after the surgery and one group didn't. And of course the group that had the little rat massage after their operation formed many fewer adhesions in their abdominal pelvic cavity than the group who didn't. So obviously the rats didn't live in the end, but that's a really good osteopathic paper that you can have a little bit of a look at as to do the techniques that we do anything. And these are just some other pictures of adhesions. And I must just say to you that you don't get rid of adhesions, okay? If you have adhesions, you have to cut through them. So if anyone says they're releasing your adhesions, they are literally talking nonsense. If the peritoneal fluid, how it works is that it's like, it's a serous fluid. It's like synovial fluid. It has mechanical properties, viscous properties. So you know, if you didn't move your fingers, what would happen to the fluid? Get a bit stiffer and stickier, wouldn't it? Yeah, and as it's like that, it's not so good as a friction buffer. So then you have to right, good, right. Okay, that's exactly what your peritoneum is like. As long as the organs are moving over each other, then the fluid remains thinner, better as a friction buffer, more immunologically healthy, and less prone to encourage adhesion formation. If tensions build up, spasms arrive, blocked breathing, the way that your viscera slide starts to slow down, get a bit impeded, and you know, you might have the odd adhesion which slows it down, but as it slows down, it makes the fluid thicker, stickier, more pro-inflamed, but with lots more pro-inflammatory markers and cytokines. And now you've got, instead of 2 bits of cling film with olive oil in between, you've got 2 bits of cling film with honey. Okay, but it's stickier. All right, now you've got cotton candy from the fairground, you know, the candy floss, whatever you call it. It's wispy, isn't it? Sticky. You can't get rid of it, can you? Yeah. Then it turns to Velcro, like Velcro, and a really stiff Velcro. Right. And after that, the nerves have grown in, the arteries have grown in, and you have to cut through it to release it. So it goes through this process. So if somebody says, oh, yes, but you did this thing and it went twang and it's marvelous. Well, great, you had Velcro stage, lucky you. But most people don't. So you can't get rid of the adhesions. You simply have to work around them and try to support how this peristalsis in that piece of bowel now works when it should be shaped like this one. Yeah, so you have to do a lot to support the structures. Okay, so I've put in some bits and pieces about the fact that it is a pro-inflammatory dynamic. Basically, if you can reduce oxidative stress in your person, if you can do anything which reduces dysautonomia and a whole variety of things, which means that they are prone to inflammation, then that's going to be a good thing. So there are lots of diet things that you can do, and there are lots of, breathing things, which I'll come on to. But also, science believes in viscerosomatic reflexes, visceral reflexes, and all of those sorts of things, because of course they're all rubbish, aren't they? You've been told to discount those entirely, haven't you? Have you? Have you been told to believe them? Work with them? Are they valid osteopathically? Come on, don't be shy. I'm sure most of you have been told that it's total hogwash, very outdated, has been researched and found to be lacking. But in fact, most of the research that has been done has not been able to be done with the techniques at the time that it was done. These days, there is an increasing amount of really good understanding, which says that, and I've got a whole load of papers there, which are about I'll just skip forwards for a minute, the reflex effects, saying that if you've got irritation in your soma, such as a spasm in your pelvic floor, it makes your bladder wall more inflamed because of axonal transport issues and cross sensitization across neurons. If you have irritable bowel syndrome, autonomically you get a dysregulation, which is the spinal cord amplifies it back out to any other similarly innervated organ. So your bladder will become inflamed, your gynae structures will become inflamed, your peritoneum will dysfunction, your vasomotion. It's a real term. It's not a stupid osteopathic term. So vasomotion is just literally the sympathetic activity and the regulated peristalsis and tone of the blood vessels and the perfusion rates into your end organ tissue. These things are all really well understood. So I've got a whole bunch of references in there. And this one I like. So only in the sense that it's now beginning to be hinted that there are ways of perhaps doing spinal work or movement-based work which could be more effective than your crack-it style stuff, or you just rubbing up the skin stuff. And a lot of this is trying to say that, like viscerosomatic reflexes are supposed to be lamina 5 wide dynamic range cells. Yeah. So the more they learn about the spinal cord, it's not just either lamina 1 or lamina 5, but these are some really interesting links at lamina 3, which links ultimately your visceral connectiveness through to your dorsal columns. Your dorsal columns do vibration, oscillation. Yeah, all of this ordinary stuff, that really boring first year stuff that nobody does because it's just not fancy. That's the only bit that's really physiologically valuable. It's really, really, really useful stuff. It's calming, it's soothing, it eases interoception, it improves segmental sympathetic tone, it gives better tissue memory, it builds body image reintegration. It's really good stuff, and they're just beginning to understand that oscillatory vibratory issues are very relevant. So don't bother trying to crack up L1 when it's the uterus or T5 when it's the stomach. Do some dynamic oscillatory stuff in that region instead. So anyway, there's lots of different things about how spinal reflexes work, which are very valuable. If you've done pain science, you'll have been told about Wilfried Janig, have you not? Well, you should have been. So Wilfried Janig, he's probably about 90 now. If you look at anything to do with the autonomic nervous system and pain, he's written all the textbooks like this. So he's world renowned, yeah, in terms of autonomic nervous system and pain understanding. Janig, J-A-N-I, umlauty thing, and G, Janig. But he came to, do you know Core Clapton? Heard of Core Clapton? Yeah. Anyway, he came to Core Clapton and gave a talk to a bunch of osteopaths, and not very many people came. But in that lecture, he was saying, and he literally stood up there and said, "Pay attention. This is really interesting for you. Did you pay attention? I'm telling you something which is really fundamental to your understanding." And what he was saying is that with his research on interneuron pool understanding is that there are ways in which the soma, afferent information, yes, it can go up, but it also goes across interferes with stuff that's going down to the ventral horn and stuff that goes back down to the, and re-inhibits the dorsal horn as well. And he says these interneuron spinal segmental reflexes are the bee's knees, and they explain what you are interested in, he said. And you know, straight up his head. Okay, but there is emerging understanding. So me personally, what I look for in a spine is that I don't look for these glowing red hot bits. You know, that's what's supposed to be the osteopathic lesion, isn't it? It's supposed to go wonk, wonk, like Rudolph's nose. Yeah. So you're never going to see one of those. What you're actually going to find is something that's really leathery, something that's very inert, something which is very fibrous and very gritty. And often if you palpate off the ends of the TPs of someone with chronic pelvic pain, you'll find these really nasty, really gritty, horrible little bits. So if you dig your fingers into those, grind away, and they'll hate you for it, but it will do really good, because what you'll find is that you feel here, can't get in, it's too painful. Oh, no, don't do that. So you can't do any of this fancy visceral you're supposed to be doing anyway, because it hurts too much. They won't let you near it. You do a bit of this, yeah, and then actually it diffuses temporarily through just, you know, ordinary segmental sort of reflexes, and you just get a little bit further in as a preparatory work. Now, there's some other interesting things that are emerging about how you can do work to the viscera, which bears no relation to the Barral ligamentous story. It's actually about promoting abdominal lymph drainage, peritoneal fluid movement, mesenteric fluid movement, and getting your gut healthy so that the microbiome is more dynamized. So it's very important that anyone with pelvic pain that you organise, hopefully, a little bit more of their microbiome. There's a little bit of emerging research about how abdominal massage may, in fact, help your gut health and help microbiomal reseeding. But it's very important that you sort the microbiome, because it is the foundation of your immune system. And your immune system is what's going to resolve your pro-inflammatory state. So if you have someone with oxidative stress, inflammation anywhere, then it is an immunological event. So if you don't understand the link between inflammation and immune systems, then that's where you need to do a little bit of work, because if you take an immunological approach, then you're going to help their inflammation, to help their pain, to help their body image, to help their mental health, to help their quality of life. How would you do that? How would you do something immunological? Any idea? Okay, two strategies. One, you rub the belly. Two, you do something postural and three-dimensional, so that they have better lumbopelvic postural gait-related stability. All right, why would that work? So there's a lot of information which says that if you have dysregulated sort of pain mechanics and problems, then your muscle tone isn't very good. So everybody is usually giving you lots of exercises to strengthen the muscles, which is actually counterintuitive and counterproductive, because most of what happens when you've got adverse movement and patterning is that you have too overpowered contraction, and you end up with slight positive increased pressure in your abdominopelvic cavity. So most people with pelvic pain have something abdominal, something pelvic floor, something the piriformis. Their muscles are all over the place, and they don't have a good three-dimensional dynamic. The diaphragm doesn't work. You get dysregulation between the thoracic and the pelvic floor and all of those things. And in that status, they have a poor pressure profile, which is going to then lead to A, changing fluid dynamics, but B, increasing pressure, which is pro-inflamed, which will make their endometrial story much worse. So part of what you need to do is to do some generic work with fluids, but you can do some very simple things, some sort of gentle vibratory techniques and breathing sorts of techniques. But there's all sorts of things that abdominal massage can do, including changing your skeletal muscle insulin resistance. Would you know it? Yeah. But anyway, so I've just chucked in a few relationships like that. So what we're trying to do with our work is to make sure that in that fluid environment that the cell is healthy. Yeah. So if all of that peritoneum can be flushed through, all of your uterus can be kept, you know, nice, lots of venous drainage. If you get good breathing, sucking up all your abdominal lymph, all of that, those cells are going to be more healthy, so therefore they'll be more physiological. So who was the founder of the school? Who founded the BSO? When was it founded? Chuck me a date. Thank you very much. So one of the best things that you can learn is about Little John's equation, which, anybody know what that is? Doesn't matter if you don't know. So if you have a cell, it has to be in a good environment. And lots of people say that you should have good arterial stuff. The rule of the artery is supreme and all that nonsense. Yes, you have to have good nutrition coming in. But Little John would say, well, that's fine, but there's no point putting good stuff in unless the, if you like, metabolic process, the byproducts have been drained away. So the elimination side of the equation, nutrition, elimination, cell in the middle, is the elimination side of things, which is more helpful. So you must keep tissues drainage, you must keep tissues fluids moving, and you must support global fluid return processes. So if you have someone with endometriosis, then you'll find that your ordinary stuff, foot, legs, knees, hips, a bit of shoulder, get them walking a little bit better, will actually be much more regularizing interoceptively and in terms of tissue health than you trying to work out what some fancy thing was on the uterosacral ligament and you can't get in there and it hurts and was it supposed to, you fall to pieces when you're like that, and that's, you forget the really simple stuff, and the really simple stuff is really good. Anyway, so we won't worry about too much about that, so we'll just play this in the background. So this is just one sort of technique where you go nice and slow and you go nice and calm, and you're just moving the viscera up and down, okay? So you don't need to know any names of any ligaments. You just need to be able to take hold of the whole abdomen, and you just need to be able to move up and down. The patient doesn't even need to be told to breathe in and breathe out. You're just looking for resistances and just moving it. So as a restoration of movement, it's something that's really good. Now, we won't, I can show it to you live in a second, but we won't have time to go through many factors. But when you're dealing with someone with pain, just even approaching this is awkward. Yeah. So people have a lot of emotional responses to pain, their pain behaviors, their personalities, and so on. And so, give you a moment. There are lots of reasons why nerves don't recover. People have pain, they don't sort of want to change things, or they feel threatened or insecure, or things aren't going right. And so if people don't recover, it's probably got nothing to do with the fact that you're rubbish at the technique, right? It's highly likely that that's irrelevant. And in fact, it's much more likely there's other things going on. Now, there's all sorts of stuff about the polyvagal theory, which we could talk about another day. But I would just remember this picture, even if you can't read it very well, because this is all about how, when you think about relationships, when you think about sexual relationships, and I don't care about genders and couplings and all the rest of it, it's all going to be priming your reproductive circuitry. There is a very special relationship in your midbrain and also down into your lumbosacral cord, which means that when you are feeling a bit, maybe there is this really good priming of your lumbar musculature. Now, if that circuitry goes wrong, your lumbar musculature is permanently up the creek, and your gynae is go, all of your other anatomies go, no, what? And then because you're not getting the right releases back up into the brain, your brain's going, and your amygdala is agitating, and it's causing all sorts of problems with your vagal and autonomic and limbic circuitry, and that promotes all sorts of like, and you get these extra florid additional components. So this sort of paper is why you have two parasympathetic components. Have you ever really wondered why you have to have two? Why doesn't the vagus just go all the way down? If the vagus is so marvelous, why do you have to have a pelvic parasympathetic bit? What's the point? Yeah. The vagus comes from the brainstem, and the vagus has connections with a lot of facial, throat, and other muscles, which are to do with swallowing, nutrition, and so on. So the vagus has to use somatic structures in this locale So it has to have spinal trigeminal linkages in order to vaguely, viscerally innervate your swallowing, for example. And at the bottom, you have to have a pelvic parasympathetic because it has to join and synapse with pudendal nerve and other pelvic innervated somatic structures so that basically your pelvic muscles go, and they do that thing with so as your glands get going or you get an erection if this is the male version. All of that physiology is tied in with your somatic tone and action. And so when your gynae stuff is not quite right, it sends all the wrong signals. So your muscles go, yes, am I supposed to be, what am I? And so you get all this tension, which is a response to confusing and dysregulated autonomic structures at a brainstem and spinal cord or sacral cord level, and which is why a little bit of rubbing of your uterosacral ligament isn't going to cut the mustard. So there's lots of things that we could do about the vagus and diaphragm and the two parts and all sorts of things which we won't have time to go through. But one thing I want to say to you, this whole story with biopsychosocial, I was a bit rude and flippant earlier, but actually what you want to do is to find a way of using your hands in a much better way to help people have a sense of security, decatastrophize their pain response, get to be able to connect instead of, oh my God, no, I can't touch it, I can't think about it, no, please, no, just, you can use your hands to actually stop this fear, catastrophizing, anxiety, depression, pain experiencing loop from getting worse and worse and worse. And the words that you use, yes, they might be useful, but the words that they use are really important for you to listen to, yeah, because they're also going to be your guide as to whether you're getting them better. They're going to start out saying, it's awful, it's terrible, it's cutting, it's desperate, you're not listening to me, people never listen to me, I've been to everybody and it's just really bad all the time. And then gradually, some weeks later, they'll say something, yeah, it was a bit better, but it's still, it's still really awkward. But yes, okay, yes, I can feel that bit relaxing. But yes, but it's still, there's something about it which I really don't quite like. And then gradually, after a few more sessions, they'll say, yeah, I'm getting a bit of respite, which is great, but I'm just really afraid it's all going to come back. And this change of wording, there's been lots of research about this, is going to be something that you can watch to monitor. Generally, because if they're starting to use different words, cortically they're being different, which is a way in which you can understand how their autonomic nervous system is down-regulating, which ultimately means that their ability to do, to have better physiology is going. So we'll skip right to the subperitoneal space. So very briefly, a little bit of anatomy after all of that. It's a really tricky area because it's really tucked down deep. You may not realize that your uterus is poked up in your peritoneum and that all of your broad ligament is peritoneum. And so you have most of the ligaments around your uterus, they are peritoneum, and it's literally as though I've got my uterus and I've stuffed it up in there. So what you're doing, of course, is trying to rummage on these organs on top, trying to get through onto there. And then you've got some other little ligaments around the cervix. So if I do my ghost impression, okay, so I'm the ghost, broad ligaments. My two sleeves are the broad ligaments with my fallopian tubes in place. And then I would lie down. Oh, my bladder. Okay. So I'll be like this. I'll be like this. This is what I'm supposed to be doing. And I've got these other little ligaments here. And actually my cervix is its own little thing, yeah? And functionally, embryologically, it's quite different. It does need to be primed and pointed in the right place. And so you've got your uterus, and you've got your bladder, and you've got your pelvic floor, and you've got a funny leg, and then your pelvis is a bit twisted, and then you've got these organs. And then this again. And it's no wonder that things sort of start to get a little bit awkward. And so there's no one right thing to do because none of those structures are going to move independently. Now, this is another nice little thing. Flat surface. So your broad ligament, if I have a tiny little sleeve, my uterus inside, and I flap it down, it makes like a little surface. Yeah? You imagine that I've got my little uterus in there, and I flap it down. Yeah? Then there's this little sort of shelf. You've got a shelf at the top, just a broad liquid, and you've got your pelvic floor underneath, which isn't a flat plate, it's a funnel. So you get this little space, okay, which when everything is swollen, inflamed, congested, irritable and so on, gets really pressured, inflamed and soggy. And it's like having an enormous swollen bowl of porridge between two immovable layers. Your pelvic floor is seized up, the peritoneum is scarred and stiffened, and that area just does not move at all. And so, of course, it's never going to self-mobilize itself. Then you've got all these other delicate little arteries, other little things that you can move about. And in terms of endometriosis and conception, this is a really nice picture. This is your fimbri, and this is your ovary, wrapped in its own little sac of peritoneum. And your fimbri is supposed to go over it and just sort of, and then literally they walk over chemotactically, sniffing, so to speak, chemically, as to whether the whether the ovum is ripe. And so it's like the constant gardener. Yes, no, yes, no. Ooh, yeah. And it has been known, okay, blocked fallopian tube, only healthy ovary, or the other way around, yeah. So that you can get one functioning tube all the way over to here. Yeah. You still end up with a pregnancy, you know, that's the only ovary that works. Not very often. But so when you have these structures, all these ligaments, it's all about trying to get things three-dimensionally a little bit more supple, gently get the pelvic floor moving, relax the abdominal wall, get some breathing, ribs, all sorts of things. In the research papers higher up, it was actually all about breathing. And I will just say I had the most ridiculous conversation with people unnamed on Facebook who were trying to, because you know you're not supposed to treat anything if it doesn't hurt now, aren't you? So like it's supposed to have pain, and you can't treat distal areas if they're not in pain, because therefore it's irrelevant, okay? Which totally, if true, would destroy the fact that you would work on the rib cage to improve the breathing. And if the breathing is better, then they can do better mindfulness, and that helps their pain perception, doesn't it? Okay, no, because the ribs are those things don't, where they're not relevant because they're not in pain, so you can't treat them. And I'm going, so there's some papers about that side of things on there. Here's just one for you to look at very briefly. Okay, so orient yourself to this one. Synthesis, bladder. I know it's got backward, it's like happening for a reason. Uterus. Yes. Look at the distance between cervix and top back of bladder. Okay, this is the question. Okay, now compare it to this one. Oops. Give you a moment. How many bladders have you got? Okay, male pubis, obviously male penis. Female pubis, female bladder, female uterus. Look at that distance now. Yes. Look at where that cervix is pointing. Keenly. And then look at where it came from. See how elastic it's all got to be? So when you've got someone who's got all that tense, inflamed, tight peritoneum, organs, and pelvic floor and all of that sort of stuff, and you go in there and start doing all of this and go, oh my God. But then just momentarily, so we're presuming this is like a male-female couple. My words have come out that way, but so you imagine the guy who's trying to, you know, and he's sort of staring down at his partner. She's going, oh, it'll be all right, and he's going, you know, that's the most wilting, terrible thing from the guy's point of view. So it destroys all sorts of aspects of relationships which are going to be relevant. So there's lots of techniques that we can end up doing. Most of these you have to do a lot of preparation for. So this is your classic, you know, suprapubic sort of stuff, but it's not going to be something that you can just dive into straight away, because again, it might be too painful and too awkward for people. So it's all about finding structures. But if you use accessory movements like working through moving the visceral mass and mobilizing the pelvic bowl, you'll get a little bit better. I'll show you these live momentarily for those of you that are able to stay. Again, there's all sorts of variations on a theme, which is, yeah. So when people think that they're going to do gynae stuff, they think that they're going to get straight into that. But what you have to go through, just very briefly, are people who have had lots of abdominal surgeries. They have lots of real problematic abdominal walls, and you never get to do all the things. You know, you open up your visceral textbook and it says to do this, 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 and this. You'll never do it, because the patient's tissues won't let you, and it's going to be too painful. So you have to offer them something else. And if you do nothing else other than work on the abdominal wall, that bit, you know, that you forget when you just ignore it and you just don't even think about it, you just penetrate to the organs, don't you? If you do the pelvic floor, the abdominal wall, bit of general breathing, their feet and gait, you will help people with endometriosis and other gynae pains. So I'm just going to, I must finish just with these two little videos because they explain everything, okay? So this is somebody who does not have endometriosis. They're normal, they're lying on their back on their scan and they're being scanned, they're just breathing in and out. So Mr. Fujiwara is the author of this paper. You can go and have a little bit of a look. So it's a bit of a speeded up movie. So hopefully we'll get it on. This is all your peritoneal intestines and peritoneal normal peristalsis, rather, peristalsis. It's a bit speeded up. The bladder is full anyway because they fill your bladder up for imaging techniques. You've got the sacrum at the top right of your picture. Okay. So the autonomic innervation to this is okay. This is a bit speeded up for the movie. They've got some, you know, the bladder's being prodded up and down, doesn't mind, quite stable. So things are sort of calm, they're active, they're sort of doing something. And then you're going to look here. What do you see? See that little ribbon? Normal uterine peristalsis. All day, every day. Varies a bit according to your hormones and all that stuff. Just does that according to its little innovation. And of course, when you've got all that inflammation, you've got these reflexes, and it's so the guts are like, or they're like, yeah. And so now you can imagine if you put your hands on the abdomen, it's going to have a certain quality of feel. Anyway, look at the next one. This is someone with endometriosis, also 2 adhesions, the blue arrows. I'm sorry, I can't move those, and a retroverted uterus. Okay, see, that is not the same, is it? You put your hands on there, you go, oh, that is not the same. So why is the bladder now got these funny peaks? It's because of an adhesion. And so as things move, the bladder is being, and so of course you're going to go, oh my God, I need to move, you know. And you've got your retroverted uterus, which can't move back. So you can't put it back osteopathically, because when it's like that, it's got adhesion stuck to it. So it's stuck in that position. And so this bit of bowel doesn't look anything like the last bit of bowel. Okay, and what do you think receptively is these organs are going to be telling the rest of your nervous system? Are they going to be sending back signals that this is all good? Okay. So your job, if you like, is just to try to ameliorate stuff, ease it off, soothe it down, calm them, get some breathing, move things a little bit so that things can regularize as much as possible. And when it all builds up again, you start repeating it again. You just, it's okay to do the same thing. And lastly, can you see any peristalsis in there? It's not the same as the other one, is it? So it's just not doing what uteruses should do. Okay, all right, well, look, that's a complete tour de force of stuff. So I hope that you've got something useful out of that. And I'm happy to stay and do some hands-on, but if you need to go, obviously, don't worry about it and run off. Any questions? Yes.
When you have expressed uterus, like in the last